it's us three, right? Yeah. All right, so we'll probably move through these a little bit quickly, but we just wanted to kind of go over some of the major updates that affect us for this year. Do I have to turn this on? Oh, there we go. I think we have all talked at this point. So, oh, you're up first.
Okay, so we talked earlier. So Mary asked me, Spencer may have been Dr. Catalano's first fellow, but I was probably his most stubborn. We're going to talk about 30469. This is for nasal valve remodeling. Again, same disclosures, but they are relevant here. Oh, that moved a little bit. Okay, so 30469 is nasal valve remodeling with low energy, temperature controlled, radio frequency, etc. Here are the RVUs. I'll leave for pictures. So doing this in the office is highly cost effective, especially for Medicare patients. The facility actually gets paid quite well too, as far as your ASCs. They will not be disappointed. It pays them better than a septoplasty. So this works out for everyone. So this code can be used alongside the septoplasty code, any turbinate code, as well as 30117, which we'll get into here in a little bit, can also be used in the setting. We'll go over 30117 in a little bit. As kind of a fill-in for 30469, but you have to be a little careful with your wording, because you're technically billing a swell body reduction. So coverage, Medicare is awesome. Medicare works great. I just got back one of my 30469 with 31242, which is the rhinitis ablation. I think it was about 3,500, maybe it's 36. I did not use a 30117 because they didn't have swell bodies. There are some silent payers, but you have to watch out for the specific negative payers. So these are going to be really, really tricky. If it is not one of these, you need to get a predetermination. So not a prior auth, because they will oftentimes, they'll give you that you don't need to, you don't need a prior auth for this particular code. But then they'll come back and not pay it. And so you would recommend getting a predetermination for these. So 30469, that's it.
So the negative payers are not?
They will not. Yeah, so it's considered experimental with them still. And so if you use the 30469, they will not pay. It's being worked on.
What modifier are you using, Joe?
52. So, the question is, you get the answer all the time. Okay, I'm going to do this procedure. You don't need pre-authorization.
Right.
And they'll come back.
Yeah, that's where the predetermination comes in.
So, you insist in every case that you say, you hear from the other side saying, oh, you don't need pre-authorization. You go ahead and do it. You're not satisfied with that answer.
Yeah.
You push forward.
Prior
Or you can just charge cash.
Or you can charge cash, which a lot of us are doing.
Okay, I don't know, for some reason it pulled my thing over there. Anyway, same disclosures. The codes for posterior nasal nerve ablation 31242 is radio frequency ablation, so Ryanair, and the newer one that you were also talking about, the Neurovent. 31243 is cryoablation. The diagnosis codes that can be used are listed: chronic rhinitis, vasomotor rhinitis, allergic rhinitis, the other specified disorders code, and postnasal drip can be used as a secondary code, but don't use it as a primary code. It won't get paid. Inferior turbinate ablation, the reason that I put this in there is for two reasons. Number one, I treat the posterior inferior turbinate mulberry tip and all of my posterior nasal nerve ablations as well, so it's an extra code that you can add on to it, as Joe was saying, adding on these extra codes. And number two, if you're using the Rhinology wand, you can use it for both. So what I'm doing, because I'm doing it intramural with the laser, I'm actually using the 30802, so it's paid a little bit more, not necessarily a whole lot more. And most of these codes are unilateral. It doesn't matter, unilateral or bilateral, you're going to get paid the same. The diagnosis, obviously, is hypertrophy of nasal turbinates. Destruction of nasal swell bodies, again, pointing to what Joe said about treating all of these different areas. So the actual terminology: excision or destruction, example, laser, intranasal lesion, internal approach. Again, you can use the Rhinology wand. So if you're going to do, and obviously you can use the laser for all of these as well. So really only difference between using the Rhinology wand for these three procedures and using the laser for these three procedures is that you would use 30802 for the turbinate. Now, the permissible billing for 30117, if you're doing both sides, you can't use a -50. It's not a bilateral code. You either use modifier excess or modifier 59. It depends on the insurance company. You have to check with the insurance company which they accept. The other thing is you can only do 2 units. So if you're going to use 30117 because there are 2 areas that you want to submucosally ablate on the right side and 2 on the left side, you're only going to be able to build 2 of them. You can't build all 4. So you have to figure out a different code.
So I'm using a modifier 51 for 30117. Is that something that you use?
No, we're using XS or 59. And we actually got that through, I think it was Barbara Capozzi, said that those were the appropriate ones to use.
51 is technically multiple procedures. Or not even separate site, but multiple procedures. So a lot of insurance companies don't even look at it anymore because it's just assumed that you're submitting multiple codes, you're submitting multiple procedures, whereas 59 is very specific. This is a different thing, even though you think it is. I didn't realize you couldn't build it bilateral.
No, it's like having a.
No, -50 won't get paid.
Like you don't say this, I took off a left mole and a right mole, because you took off 2.
Reimbursement. So this is average reimbursement across the country from Medicare. Rhinology, about $2,500. Again, it doesn't matter if you do one side or both sides, and actually if you do one side, you're supposed to use the modifier to get paid less. Same thing with the 31243. A little bit less for Clarifix than Rhinology. The 30801, which is the superficial ablation of the turbinate, 219. If you do it intramural, in other words, if you do it with the laser instead of with the Rhinology, you get a little bit. You get about $60 more. And then 30117. If generally speaking, Medicare is going to pay you 50% less for the second one, so it'll come out to about $1,500. The Valent laser, currently, this is the way I would bill it. which would be unfortunately the unlisted procedure for using it on the posterior nasal nerve. And then for the mulberry tip, using the 30802, unless you're doing it different, Joe.
I use the 99 if it's a self-pay scenario.
Mm-hmm.
Any other case, I would use the actual code with the modifier.
So you would use the 242 with the modifier. And what kind of reaction are you getting from insurance when you do that?
50-50.
Okay.
What modifier do you use? Say again? What modifier do you use? I agree, and you have to document it carefully, and that's, temperature control ablation of a certain area with different technology. That's why you're using a modifier, because you're kind of off from the described CPT procedure, specifically indicating one power or one energy source. It's better to use the 99, but you're opening the full capacity.
And then I have the less sexy codes. This is a potentially an important one. G2211 is a Medicare add-on code meant for outpatient visits. And basically, this code was in essence designed for primary care physicians to improve their reimbursement. And so actually, I think at the time that this was being discussed, I was on the board of directors of the Academy at that point, and there was a huge controversy between the American College of Surgeons and the ENT Academy because of this code potentially going into effect. And as a justification for reduction of Medicare reimbursement across the board, so primary care would get this, but then surgeons would suffer because the pie was getting shifted. But when you look at the amount of kind of longitudinal care ENTs provide, net use of this code, at least in the Medicare system, improves our reimbursement by about 4 to 5% overall, as opposed to taking a complete hit. So this is used as an add-on code for an outpatient visit. You report this G2211 as an add-on code, and in essence, it goes through as about an additional $15 of additional revenue per patient that you see with this code. But it's not to be reported at the same time that you're doing a procedure that day. So if you're using a 25 modifier because you're doing an endoscopy or a laryngoscopy or some other minor procedure, you would not report this code. It's intended to use that you're demonstrating longitudinal care for a patient. So not a terminal visit, not like, all right, well, I'm treating rhinitis and they're great, follow up whenever. It's long-term things. So chronic rhinitis, chronic sinusitis, allergy, head and neck cancer care, salivary gland disorders, hearing loss, refractory reflux, all of the things that you're going to see them for potentially on a continual basis where maybe it's a lot of empiric therapy, changing therapy from visit to visit, but not doing a procedure at that time. You can put this add-on code for the Medicare patients to basically just get a little bit more out of the thought process of how you're manipulating their medications or their treatment options and that type of thing as you manage this care over the continuum of the patient. So given the amount of longitudinal diseases we actually manage, unlike a lot of surgeons where it's cut and done, because we're the medical and surgical providers for a lot of these diseases, it has a potential huge role in increasing reimbursement for us. And then the other thing that, in the interest of time, we don't necessarily need to cover unless anybody here works in a hospital facility and has a nurse practitioner or PA working with them. But in essence, they changed the rules for if you're using an APP along with you. So in my clinic, I have a nurse practitioner. We're seeing patients at the same time. She's really doing a lot of the intake, and then I come in, meet them, say hi, review all the data, kind of formulate a code, and then I move on. And so they changed it how you document and do that. So if you do function in that type of an environment in a hospital outpatient facility, this doesn't apply to private practice. at all, then you just need to be aware about the updated requirements for documenting and billing a split shared thing. And that's it.
For the longitudinal care, is there a sentence that should be included? Like, is there a recommended, like, I am providing longitudinal care for this patient?
Not according to our compliance officers. It was simply just,
Some sort of chronic.
yeah, it's a disease that has a chronic diagnosis code. Yeah.
So you can't do it when you're under nasal endoscopy.
Right. If you're doing endoscopy at that time, then no. And you know, and you'd say, well, it's probably few and far between. But there's times when I see a patient for their allergies or their sinusitis, and they're like, well, I'm doing good. And I'm like, all right, can I really justify putting a scope in your nose if you're doing fine? No, but I'm managing a chronic disease. Put the code on. So, okay. Thank you. Well, you're not using a more complex. You know, if you've got one diagnosis, chronic, unchanged, right? Then I don't know what that lands you as like a level 3, right? But then you tack this on, you know, as opposed to like, let's say you change their medication. You know, they says, oh, I'm a little bit more stuffy than normal, and you'd say, okay, well then let me increase your mometasone dose. Okay, well now you've got the risk associated with medication management, so maybe that's a level 4. Well, but if I didn't scope them, I can still then tack this thing on. So it's a complete just add it on. Like you determine what the code is for that patient's visit based on everything you did, and as long as you didn't do a procedure with needing a 25 modifier, this is an add-on code for another $15. It's just, it's where you are, in essence, you're the one assuming care for this disease that you'll be treating them for on some regular visit.
You can use it with a new patient code.
Right.
We're usually scoping new patients.
You can use it on a new patient code if you don't scope them. But it's a disease that you're going to say, like, I'm going to be managing this as opposed to a one and done, or it's the terminal visit. Like, oh, your allergic rhinitis is resolved. You know, like, I'll see you back in 3 months to talk about your reflux. But then, so you wouldn't technically use it then. Yep.
That works very well for sleep apnea patients.
Exactly. Yep.
A question to both of you. You know, a lot of times I do procedures one side at a time. You know, let's treat, you know, Mr. So-and-so, your right side is worse. Let's treat the right side first, see how we feel, we're getting a success, etc. And we'll wait 3 months, we'll treat the other side. Many benefits, obviously. Faster recovery, less swelling in the nose, etc., etc. And it kind of shy to have the procedure on both sides. How do you deal with the billing aspect?
Well, I mean, most of these codes are, you don't get anything extra for doing bilateral, so I mean, that's helpful because you're not going to get full reimbursement from each side. So,
But you should technically use what is it, 22 modifier for reduced services. If you're going to do one side with a 30469, then you should use a 22 modifier for reduced services if you're going to only treat one side.
You mean 52? 22 is more complicated.
Oh, shoot.
52.
Yeah.
but
Yeah,
you would
it's
still,
not more
you would
complicated.
still ultimately, I think, make more even using that modifier by doing it separately.
My patients do not go for that. I need your.
But it's not, you don't get paid 50%.
Yeah.
Yeah, I personally, I think there's some ethical issues in staging a procedure if we're, and then having a similar conversation about optimizing reimbursement. So,
Well, it's like, it's like people that, when they're treating chronic sinusitis with the deviated septum in their office, and they say, okay, I'm going to use septum, and then surgery center, I'm going to do your wound sinuplasty.
oh yeah, no, I'm not saying that that's permissible either. I just, yeah.
No, I mean, I don't know.
I know, but I don't want to be on the stage being recorded saying that we should have a conversation about unilaterality and optimizing payment. Yeah, okay. Yeah. Yeah. All right. I think we're 15 minutes over. Okay, thank you.
Okay, so let's see how this works. Back for this laser, perfect. Okay, for summary, can you hear me? Okay, so they asked me to talk today about an update on basic tongue implants and stimulation for sleep apnea. Okay, so next. Disclosures, I'm a clinical trial site investigator for ImThera, and I'm an advisor for Sleep Care Company. Basically, at this point, there are a lot of people trying to do stimulations, but there are really three systems active in our conversations. Inspire, which is FDA approved, data published and reviewed. There's ImThera, which is a clinical trial, and the data has been presented in the American Thoracic Society and some other places, so I could talk about it. But I will be, as a principal investigator, only talk about things that are public knowledge. And then there's Nyxoah, which is a bilateral. It's been approved in Europe, but has no published data in the United States, so I have nothing to talk about for it. So that brings us to treatment, basically, of Inspire versus ImThera, and that's what I'm going to be talking about. Let me go through the physiology and then the results. So the physiology of Inspire and ImThera is very different. Inspire, whoops, let me go back here a second. Inspire stimulates the genioglossus nerve and the throat to open up. So in this depiction of respiratory volume and respiratory rate during an apneic event, there's no respirations, and then Inspire fires, and you get movement of the tongue opening so that there is air flowing through the mouth. So Inspire creates the opening in the oral pharynx and the tongue to breathe. And that is different than what's going on with ImThera, which basically raises the resting potential of the genioglossus muscles and the muscles that it enhances. It's based on this very old physiology experiments, normal subjects and sleep apnea subjects, involving the resting potential EMG of the genioglossus muscle and the tensor tympani. This is awake, and then during apneic events, this is a normal patients. And in a sleep apnea patient, the genioglossus muscle is normal and awake, but at asleep, it has a lower resting potential than a normal patient. The tensor tympani also is lower, much lower than in a normal patient. When they're awake, they're stimulated, and when they're asleep, they're non-stimulated. So we get airflow when they're awake and no airflow when they're asleep. So it's a muscle function problem, addressed differently. So in the two systems, again, Inspire and ImThera. Inspire has a pulse generator that has a sensing lead. It doesn't go in the chest anymore. It's usually underneath the generator. And it has a cuff that goes over the branches of the facial nerve, of the hypoglossal nerve. In ImThera, there's no sensing lead. It's just a stim lead to the body of the hypoglossal nerve, as opposed to the branches of the hypoglossal nerve. So this is Inspire, which is the anterior tongue, and this is the teeth, and the Inspire goes to the branches of the hypoglossal nerve that stimulate the contraction of the genioglossus muscle and geniohyoid, making the tongue go forward, and avoids the styloglossus and hypoglossus. As opposed to ImThera, which has a cuff over the entire branch, the entire hypoglossal nerve. It has 6 contacts along the cuff. Typically, only 3 are turned on. And again, it's a tonic stimulation without respiratory synchronization. So it's not syncing, it's just kind of an on-off, 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 on-off. This is kind of what a cross-sectional area. Let me show you that a little bit more. So this is the concept here, is that the event is here, nerve cuff, and it's wrapped, the hypoglossal nerve is wrapped around, there's 6 electrodes, and the reps basically figure out which combination of the electrode placements works best for the patient's stimulation. And this is what it looks like if you have to get chest X-ray. They're sitting right over there. This is an Inspire. Oh, this is Imthera actually, which sits in the chest. So I think everyone's fairly familiar with the need for a dice. See if we can get that to play. Oh, there. So this is a concentric collapse where you are not you fail candidacy for Inspire, as opposed to AP collapse. Like get these to work right. We'll see that. There you go. This is AP collapse of the nasopharynx. I think everyone's familiar with what a dice is already. Just to show you, this is AP collapse versus circumferential collapse. You do not need a dice for Imthera. So Imthera is all comers, then they're not screened. So this is a picture of the placement of in Inspire. This is the hypoglossal nerve branches that are separated along. We also include C when we put it on. So this is separated out from the entire nerve, which you see sitting here. This is courtesy of Maria Cerna. In Imthera, the cuff goes over the entire body of the nerve here. And these cuffs all look very familiar, very similar rather. Silicone with electrodes on it is what the electrodes look like. And this is an Imthera implant. And again, you see retraction of the digastric, and the implant sitting right in over here. Or the cuff is sitting over the nerve right here. So in both the Inspire and Imthera, we test them intraoperatively before we close the wound. And let's see if this one works. Can you get... Well, we got the sound, but we don't have the video. Oh, there we go. Here we go. So you'll see here the tongue movement. It's not coinciding with the sound, and this is an Inspire. One of our first ones where we draped them a little differently. You can see movement of the tongue. Another one. Let's see if this one goes. And you'll see here is the nose, the wound, the tongue. There you go, see it protruding out. Again, this is the tongue protruding out, testing intraoperatively. And this is an Imthera patient, testing intraoperatively. This is the chin, right neck. This is the chest, head, wound. And you'll see movement here. So you can see the movement of the tongue. Subcutaneously, we don't want, so you can see it going back and forth. So both are tested intraoperatively for effectiveness. The results of these are variable. Just one thing I wanted to say about the testing. The initial testing is, and the trial. In Imthera, I found very fascinating because what they did was some patients, Inspire was just work or not work. It either tested the patients for efficacy or not. In the Imthera trial, they've actually took some patients and turned the therapy off and tested them and then turned it on again. So there's some people that go on and off to test the efficacy of the machine. TH3 is Imthera, and STAR is Inspire. These are adverse reactions. They're similar: skin erosions, tongue movement impairment, loss of therapeutic effect, some explants from arthritis, or other intolerability of the machine, of the implant, and particularly the electrical stimulation. Long-term results, and Inspire is very good. This is just to give you a baseline. We don't really have comparative data, but the idea is from pre-op AHI to post-op is very good. The median for this is in ImThera now. That was Inspire for median apnea-hypopnea index. Both the yellow is ImThera, and the purple is Inspire. And you can see the variations. It's starting out in different areas, but the median hypopnea index drops dramatically for both. Oxygen desaturations drop dramatically for both. And the Epworth Sleepiness Scale scores drop dramatically, as well as the functional outcome scores. So ImThera is a safe and efficacious alternative for treatment of sleep apnea and a 3-year follow-up. Both studies were comparable, despite the fact that in ImThera there is a greater OSA severity in the ImThera trials. There's a wider enrollment criteria. In other words, we didn't, in the ImThera, there's not testing them for collapsibility and eliminating the concentric collapse. And there's a potentially wide range of therapies for the ImThera. Ongoing trials. There's a second study for ImThera that just closed last week to have the required amounts, hopefully, for FDA approval. Thank you very much. Questions? I put you all to sleep? Okay.
Why you stay there? Because our next speaker is moved for tomorrow.
Oh, okay.
You're on with
Ash, no, just before we go on, Ash, you're doing a lot of Inspires. Do you have any comments? Okay, so we're not doing Nixo. What do you think about those? So Nixo is the bilateral implants. You want to talk about that a little bit? Pardon? Try what? Right. And I've heard through the grapevine some of the initial implants that were bilateral, there were some significant complications from swelling. Do you, can you test it before you close? Yeah, it moves. Huh? Other people have told me it moves also, yeah. I've heard it moves, yeah. But the other issue I heard was this is all rumor, nothing true, that some patients have had excessive amount of swelling and difficulty swallowing afterwards from it. Okay. Welcome to our lives. That part I know. Any other questions? All right. Let me go on to my next talk. My next talk, yes. It's on compliance, CPAP, nasal surgery and CPAP compliance. Okay, so they asked me to talk about compliance and stuff. This is a fairly short talk, and you'll see why in a minute. And I have a little extra information for you. Okay? So they asked me to talk about CPAP compliance and nasal airway surgery. In other words, does nasal airway surgery enhance CPAP compliance? Kind of makes sense. It might help, right? So I'm going to talk about nasal surgery that facilitates the treatment of sleep apnea by improving compliance with CPAP. I'm also going to want to make a few comments about nasal surgery that can successfully treat sleep apnea. So nasal surgery can facilitate the treatment of sleep apnea by improving compliance with the therapy of CPAP. This is a very, very interesting article. It was a meta-analysis by our friend Rob Capozzo at Stanford of 18 studies and 279 patients. That's a lot of resident work doing this, okay? 279 patients, mean average was 53 years old, mean BMI of 30. CPAP compliance was defined as using CPAP less than 2 hours a night for more than 70% of the time that they were treated. The patients were evaluated before and after nasal surgery, septoplasty, turbinoplasty, rhinoplasty, or combination of treatments. This is my COVID masking pictures. Craziness. So, in this analysis of 18 studies and 279 patients, compliance with CPAP went from 39% to 90% in all patients. How do you get all patients? 90%. 18 studies, 279 patients. 89% of the patients not using CPAP before nasal surgery used CPAP after nasal surgery. I'd say that's pretty effective therapy. They were doing no treatments to treatments, and essentially 90% reversal of therapy. So it's hard to argue with that amount of patients. This is a great single study that I found that is very interesting. It's a how do we go back? Yeah. It's a prospective study of 49 patients, all with an AHI greater than 30, all intolerant of CPAP, all failed medical correction of nasal obstruction. So they had medical therapy for nasal treatments. They were treated with septoplasty and radiofrequency reduction, powered turbinoplasty, or radiofrequency turbinate reduction. Okay? That thing's down there twice. All right. So, results. 100%, 49 out of 49 patients reported tolerance of CPAP greater than 4 hours a night for more than 70% of the nights they were treated. CPAP pressures required to treat them dropped, and the total amount of sleep time on polysomnogram increased by 41 minutes. So, you can't beat 100% treatment. And so when I looked on to look more data on this information, I feel it was kind of worthless, since this is a very direct, distinct effect, and going over the same thing for the next 4 times, I don't think it's going to add any more information to you. So it's kind of the end of my explanation that CPAP compliance is very, very affected by nasal surgery. And you should be able to tell that to patients, evaluate people that are on their CPAP, and tell them if you're not doing well, you need nasal surgery. And there's no doubt it will help you. Surgery is better than medicine.
Regardless of the type of mask, full face, nasal, or pillows, or any other gadget?
If they're not tolerating it, they didn't say, well, you know, we assume that people that have tried this have tried several masks beforehand, and whichever mask they're more comfortable with. So they've already tried the different masks before they just quit. My personal experience is that not necessarily true. The patients very often have one type of mask, and they don't complain and get the pillows or the other types, and I have to encourage them to change them out. But either way, when you got everybody using it afterwards, no matter what it is, the nasal surgery really works to improve it.
How about nasal surgery and oral appliance? I think Madan will make some comments on that maybe, because his group really pushing the concept of airway with the oral appliance activities, etc. So when you compare CPAP on one side, nasal surgery and oral appliance on the other side.
I think you're comparing 2 different things. One is the treatment.
We want to get them off the CPAP.
Pardon?
We want to get them off the CPAP, or at least the mild apnea.
Oh, I think that nasal surgery and and dental devices are an absolute option. I talked about that last year because, you know, well, let me go on to the next slide. I'm glad you brought this up. So last year I had a talk about whether or not nasal surgery treats sleep apnea. And I basically created a whole long talk about this last year. And I didn't show any patients that basically got cured by sleep apnea. Until our great leader here, Peter, stood up and said, well, you didn't look at everything. Because there's a really good paper about this once written that shows how nasal surgery can cure sleep apnea. So I'm mea culpa-ing this year, and I'm bringing back an article from last year's presentation. Nasal surgery can, in fact, facilitate the treatment of sleep apnea, and nasal surgery can actually treat sleep apnea. So this is a paper by a well-known person from October 20th, looking at minimal and nasal surgery for outcomes sleep apnea surgery, an effective new paradigm for reducing the apnea-hypopnea index. 42 continuous patients with sleep apnea were treated with septoplasty, turbinoplasty, or sinus surgery with sinus technique and swell body reduction, essentially on most of them. Some of them with middle turbinate concha-bullosa resections, swell body reductions, nasal valve, so whatever the surgeon felt was appropriate for it. And Peter might talk about this a little bit more. So, evaluating these patients 9 months later, total of 42 patients. Okay, 15 out of the 42, 42% went from average pre-op AHI of 25, which is not very high, to 3.8. So the patients with there were 6 of patients with mild sleep apnea. 6 out of the 12 patients. Remember, we had a total of 42. Of the 42 patients, I hope I'm explaining this right, because there's actually an error in the publication data printout. I'm sure you recognize it at one point. There's a number wrong. So of these 42 patients, 12 were mild. 12 had mild sleep apnea. 6 out of 12 got better. That's really good. Okay, moderate, again, 12 patients. 4 of these 12 with moderate sleep apnea. Peter didn't define what's mild, moderate, and severe, but we'll take it by our general concepts. And 18 of the patients had severe sleep apnea, and 5 of these patients got better, from an average pre-op of 48 to 3. That's extremely good. So in fact, there is some data in the literature to show that just nasal surgery alone can cure sleep apnea. Peter, you have any comments? I can't hear you.
I said, I'm proud of you for following up on that. You know I wasn't lying to you.
Well, I
And-
think I analyzed it pretty well for you, didn't I?
You did a very good job. So, the key is figuring out why do some go from 49 to 3 and some don't. It's very challenging to figure that out. But as a first line, and like you said, there's a dual opportunity here. There's cure, and then there's CPAP compliance. And remember, we talk about cure to a AHI of 5. The real issue with sleep apnea is reducing the risk of the comorbidities. When you get them under 15, that really is a safe place for them to be. Now, there's a big variation in how people feel with sleep apnea. Some people have an AHI of 75 and they have no symptoms whatsoever. The wife says they stop breathing, they snore, but the patient says, I don't feel a damn thing, doc, why am I here, right? I'm sure we've all had those patients. You have a patient with AHI of 6, you test them, you said, you barely have to say, oh, I'm tired, I'm fatigued. How do we know that that's a sleep apnea? It could be so many other reasons for that, right? It's hard to really know. So, the symptoms that you get from sleep apnea vary all over the place, but the risk profile, it's been shown that if you get them under an AHI of 15, the risk of having stroke, diabetes, heart attacks, AFib, all that stuff, hypertension, goes way down. And that's the goal. So I don't talk to them about a cure. If you get a cure, great. But if you can get them under 15, you're really doing, from somewhere that's moderate or high, you're doing a great job. And they don't need the CPAP at that point because their risk profile is really low. And it's not something that's really going to put them in significant harm's way. That's the way I look at it with them. So if you can get there with doing this, that's a win. If you can't, or they're highly symptomatic and all that, it's a different story.
Well, I don't think that, I beg to disagree with you. I have a lot of patients that are really symptomatic under 15. And what you're really saying, though, is the point that we were mentioning before, is that, and what I mentioned really last year, is that the purpose of nasal surgery, we tell our patients it's so that they can wear their CPAP. But the reality is, once their nose is open, then they're open to other modalities of therapy, particularly a dental device. And that's what I think you're talking about. You get these patients down from 40 to 15, then you put them on a dental device, and you'll get them down to 4 and 3. So the purpose of the surgery, you tell them, is to wear CPAP. But the reality is, in a lot of patients, what I'm thinking is, if I can just get their nose open, I can give them a dental device, and they'll do really, really well. Or a combination of therapies, weight loss, dental device. It's just not one single therapy we've learned in sleep apnea. It's got to be a whole host of what's best for the patient. Weight loss drugs now are very you can take patients with severe sleep apnea, put them on Mounjaro, and you'll get them to the point where you can just tip them over with a dental device. And so a lot of patients now I'm rejecting from Inspire because they're so obese. I go, if you lose enough weight, you might even just get to the dental device level. It's really we're seeing a reversal on patients. So it's not one therapy for patients, but a multitude of care with all these different options is what's really turning out to be the way to do it.
So first of all, I agree completely with what you say because I don't refer anyone for hypoglossal nerve stimulator implants. I don't do them, but I don't refer anyone. I treat all of these sleep apnea patients, no matter how severe, with nasal surgery and an oral appliance. Yeah. And if you have a good sleep dentist, they can fix almost anyone. And then to your point, once they've lost enough weight, they can usually, get rid of the oral appliance. But going back to what Peter was saying about why some of these patients do better than others with similar AHI, the problem is that we're looking at the wrong parameter on the sleep study. The AHI is the worst parameter to look at. Okay, not all AHI of 50s are created equal. So an AHI of 50 with the lowest oxygen saturation of 60 and an AHI of 50 with the lowest oxygen saturation of 82 are two completely different animals. And one is more of an upper airway resistance syndrome, and the other's true sleep apnea. And so, of course, those ones that the amount of time below 88% is 2% of the night are going to do far, far better with nasal surgery and an oral appliance than someone who's 50%.
What you're really talking about is the term now about oxygen deprivation burden, and how much time do you spend when your O2 sat's below 80 as opposed to being above it, the burden of the hypoxic burden. And that really varies tremendously, we're learning, and treatment of the patients is going to be different for them.
And the other thing also, coming off of what Peter said, is you have to look at the sleep stages.
You have to what?
You have to look at the sleep stages, how long they're in each sleep stage. So you can have someone with an AHI of 6 that's getting 5% of the night in deep sleep.
Oh yeah, totally different.
And yeah, it's not sleep apnea. It's an organic medical sleep issue that needs to be treated in and of itself. And so that's if the sleep study that you're using doesn't give you that information, then it's really hard to treat these patients.
Yep, I completely agree. But it's a hypoxic burden and what's going on, I think is very important. Yeah. So, it's a very changing field. It's very common. I find in my personal experiences, 5 to 6 years, they don't tolerate it well. So it turns out that you talk to more and more dentists, what's coming up is they have these things, the dentists have developed is what they call bite and grind. So what they're recommending patients now, when they finish wearing the dental device at nighttime, they have this little thing that you exercise your TMJ on a bite and grind block every morning. And it seems to be very, very effective for avoiding the TMJ problems. It kind of realigns patient in the morning. So it's a bite and grind block that people are using now. They've been very effective. And I think that's hopefully at the moment the current way to avoid long-term development of TMJ pain by re-exercising the jaw every morning after you take it off.
To piggyback off of your question, I would say that the majority of my sleep apnea patients already have TMJ because they're trying to manipulate their area when they're sleeping at night. I find the most common cause of TMJ in my practice is sleep apnea.
So if the orthodontist was here, I don't know where he is, he'd tell you all about this. He stepped out, but there are articles in the oral surgery literature about oral appliances making apnea worse. So you have to be very careful in using them, and big red flags on how you use them. Also can make the jaw itself bad, not alone the apnea bad. So there's, if you buy these over-the-counter jaw devices, they're never good. You have to get them custom made, and they have to be done by someone, like you said, like Lee said, someone who's a really good sleep dentist who knows how to do that and will manage that patient for you. But TMJ disease, many of the patients have it. Bruxism, you have a patient with bruxing, that's an airway issue. It's another red flag. It's automatic. You know if a child bruxes or an adult bruxes. Nocturnal bruxism. It's the difference between daytime bruxing. There are people who brux during the day. That's totally different than nocturnal bruxism. Nocturnal bruxism is apnea-related or airway-related. Daytime is usually stress-related. They'll be at their desk working. They're under stress. They're grinding their teeth. They're clenching. Different animal. So you have to make sure it's nocturnal bruxism and highly correlated with airway. So if you see that in your patient, again, it's like the crooked teeth. It's pathognomonic for the problem.
So this is all changing a lot. You should, every dentist on the corner is advertising in the pharmacy about their own personal device. And you've got to make sure you're getting a device that's FDA approved, which basically means it's progressive advancement of the mandible forward. All these things, you have to look for a device that is Herbst, or I like the Herbst devices or the TAP devices, in my mind have been the ones that really are only effective. And they're basically designed to progressively move the jaw forward until the patient gets to the point where their snoring and sleep apnea is improved. And so they should have some way to adjust them. This is a big problem in our community. And I have a disclosure relative to a company, Sleep Care, so I can't talk any more about it, but we'll be discussing it next year in a different manner. I suspect. Any other questions about it?
Thank you, Marty.
Yeah. Okay? Okay.
Do you have your connector? Okay, thanks. Badar, you gonna make comments on oral appliance? Yes? Okay, good. So we're running a bit ahead of schedule, but so we'll take time at the last panel. We'll use that time whenever we get to that. So one of my favorite topics in my practice is really has been tonsillitis and managing tonsil stones and cryptic ablation of cryptic tonsils loaded with tonsillitis. So you're going to say, what are you doing? Take the tonsils out and you're done with. Not that. There is an awful opportunity to chat about these things. Ash, you want to join me? Yeah, come sit here. So we'll do this together. So here is my first publication, Laser Lingual Tonsil Ablation. Look at the date there, 1989. And we published that, and this was with the CO2 laser. Again, after that, serial tonsillotomy or tonsillectomy, 1994. And why are we doing intracaps? And this is before, coblation and other tools. And the goal was to ablate the lymphoid tissue, the cryptic tonsil, the superficial part, and get rid of the cryptic pockets. What's happening with the cryptic pockets? They get dilated, filled with bacteria, gram-negative anaerobes, that they form biofilm. So that's why laser or any tonsillotomy works. You get rid of the cryptic pockets, the infections, they slow down. There's no reason for you to go down into the capsule and resect the whole thing. This is one of, I have, over 150 publications, but this paper goes probably on the top 3. And we proved that tonsillolit is not just a stone, but a living biofilm. So I was doing a bunch of tonsillectomies. I said I was doing some research with a colleague in Pittsburgh, a very famous biofilm expert. I said, let me send them some tonsil stones. He was a big researcher in dental biofilms. So Dr. Paul Studley, his name, and he looked at it. He called me a week or two later. He said, Joe, what you send me is typical dental biofilm, no different than that. I said, how come? I'm going to send you some more. So we keep sending him tonsil stones for several months. So what's happening is the crypts, they get loaded with bacteria, gram-negative anaerobes, perfect location, highly vascularized, little vessels, they start feeding. They're building this biofilm towers, they slough off, etc., and they get dilated. They get bigger and bigger. They get harder and harder. There's no calcification yet. Calcification occurs, months or years later. There is some inflammatory reaction at the depth of the crypt. As they get dilated, they are hidden there. When you squeeze them, you see just a little bit of the stone picking out and spitting out. So, and this is what happened to this guy, okay, during his, presidential debate. He's spitting out tonsil stones. Embarrassment, obviously. Forget about bad breath and other events that occurs with that. So we did, Paul did a lot of work on this particular stones. Typical cocci and fusiform bacteria, multi-species, dead bacteria, live bacteria, et cetera, and very similar to the dental plaque, corncob structures, filaments, and cocci, all mixed together, okay? That's your tonsil stone. And he did very interesting research. He put microelectrode into the stone, and he showed that oxygen has been depleted at the depth of the stone, and to a degree that is statistically different with what's happening at the surface bacteria. And then he gave some sucrose and increased that oxygen depletion. And when he added some fluoride into the mix, all of a sudden it kind of reversed. Exactly how the biofilm in the oral cavity and the dental plaque or the gums will behave. So no difference. And he came up with the answer. He said, this is not a stone, it's a biofilm, okay? So that's his conclusion. So this was done, I don't know, 15 years ago, the research. So I said, I'm not removing tonsils anymore. We're just going to do cryptolysis. I started with the CO2 laser and converted into a diode laser. So the method to extract stones is with two tongue blades, one on the tongue, one on the anterior pillar. Okay? 90% of the time, the tonsil stones are located at the superior pole, hidden behind the pillar. It's very rare to have stones at the lower half of the tonsil pockets. Most pockets are there. So what we're doing is literally, as the term calls, cryptolysis, ablate the cryptic pockets, and the goal is to get rid of the biofilm and burn the mucosa at the depth of the tonsil pocket. And you're done. So, and again, this is a paper with Ash and the relationship with biofilm, oral malodor, etc., typical the same bacteria, and that's what we're doing. So initially, we're doing this work with a CO2 laser, with a scanning device that goes back, 15, 20 years back, and the goal was to reduce the tonsil size under local and topical anesthesia in the office, and marsupialize the neck of the cryptic pocket, empty the pocket, get rid of the stone, and burn the bottom of the mucosa. So it's very clumsy to use the large CO2 laser articulated arm. The diode laser does the same thing, and we evacuating the stone, opening the cryptic pocket, bring oxygen to the new marsupialized area, and clean the pocket, get rid of all the debris, irrigate, gargle, etc., and you're done. Not much pain because you're not exposing the tonsil capsule. No bleeding because the lymphoid structures has literally very minor blood supply of the tonsil. You're not nowhere near close to the capsule, and you're working on the upper part of the tonsil anyway. So this is what you end up with, marsupialized cryptic pocket. I'll show you another case, and this is done in the OR just for demonstration purposes. And I do this rotation moves after I retract the anterior pillar, and the goal, you don't want to really injure the anterior pillar. It's going to cause pain unnecessary. And look where the cryptic pockets are, localize them, and take a look how once you open the neck of the cryptic pocket, all of a sudden the retained stone peeks out and comes out. So that's that. And usually the inferior half you don't have to deal with. So very easily tolerated, minimal pain, minimal discomfort. Literally, I don't prescribe any narcotics, and no bleeding, easy recovery in the office, or general anesthesia if you have a bed gagger. Well, that opens another topic of what we do with intratonsillar abscess formation of tissue in an acute phase. So here is a patient that was not responding to antibiotics. His right tonsil is huge. He has a retained stone that is two of them, one superior and one in the middle, and he is forming sort of intratonsillar abscess. Ablate that, marsupialize that, get rid of, drain it, clean it, and so that's toward the end of the procedure. We drain the bottom one as well. If a patient has limited gag reflex, there's no issue. And this is the end of the procedure. Eventually, the whole tonsil shrunk down and improved. So we published that experience with the CO2 laser in 2013, and this was a tonsil cryptolysis. So, Ash, I have news for you, and this is my new gig. 1,000 cases of tonsil cryptolysis is going to Dublin. I'm not sure if you're going to Dublin. I hope you are. Yeah. So this has been accepted for the presentation at the European otolaryngology meeting in Dublin in a couple of months. So I'm going to present our results there. So let me stop here and run this video, but Ash, make some comments, please.
My experience has been, Dr. Crespi is much more aggressive. I usually try to limit office cryptolysis for single dominant crypts. If there are multiple stones and you have to almost denude the entire surface of the tonsil, my patients are not happy. And in those cases, if I have to do the entire tonsil, then I would probably do either a partial tonsillectomy in the OR with the debrider or do a total tonsillectomy. Some patients want no chance of a stone forming again. The only way you can guarantee that is if you do a total tonsillectomy. It works really well for single crypts and crypts on the superior pole, which you can actually easily see and ablate in the office. I just use Sidicaine topically. More than enough. I mean, we do a lot of other procedures. We're doing juvelectomies with the diode laser. We're doing HHT for the nose. We're doing multiple things, excising partial glossectomies in the office with the diode laser with just topical anesthetics.
I inject the superior part of the pillar and the mid portion of the pillar. Very small amount of cytokine first, especially if it's a gagger. So you want to numb the back of the throat, the tongue, etc. The reason I inject because I like to retract the anterior pillar superiorly. I put my tongue blade to the side and go and dig a little deeper. You need an injection. If the pocket is visible and the stone is visible, that you don't need retraction of the pocket, Cytokine may be enough alone without injection.
Joe, what code are you using? Tonsil tag reduction, or what code are you using?
Either way, either the tag reduction, tonsil tag, or 52 modifiers. Again, less of a procedure. And if one side, we mark it one side. If it's bilateral, we do it bilateral. And I've been doing this for 20-some years now. Surprisingly, the 52 modifier has been ignored by the insurance company. I get tonsillectomy reimbursement. It's still stupid money, but nevertheless, they paid. Yes, Yusuf.
So my, all right. My question was, you kind of partially answered it. Huh? It's on. Hello? Okay. Sorry. Uh, my question, you partially answered it. What do the insurance pay for the laser tonsillotomy or whatever you want to call it, tonsillar cryptolysis? And if they pay, how much? Number one. Number two, what's the recurrence rates? And what do you do when somebody comes back with another stone? And how long does it take to come back?
Again, you get paid for tonsillectomy, whatever the insurance plan may pay, somewhere between $500 to $800, something like that. Occasionally, you can tell the patient that, hey, this is not a reimbursable procedure. If they can afford, you can use the 9/9 procedure. That's another story. As far as recurrence rate, extremely low. Under 3%, period. So we did not convert many patients to a full tonsillectomy. It's extremely rare.
Again, if it's localized to the upper pole, you have great results. If it's more deep, poor visualization. If it's between the lingual tonsils and the inferior pole, 100% chance they'll come back.
You're next.
The CACR, sleep apnea in the nose. It was sent in. It was sent in like weeks ago. It's to both the forum, the speaker ready room, and also Christina both. Perfect. Thank you. Okay, thank you. So we're going to speak about a little more than what Dr. Hop had presented. So we're going to talk about nasal surgery and sleep apnea, effect of the nose per se, effect of nasal surgery, and how it interacts with sleep apnea. This slide requires no introduction, gives you the various areas where obstruction can happen. And key here is to learn about effect of the nose, nasal pressure, intraluminal pressure, and extrathoracic trachea and intraluminal pressure as it relates to the nose. Again, the nose acts like a filter, protects the lower airway, and nasal breathing is preferred both while you're awake and you sleep. We know people, athletes, wear breathe-dry strips. It's far more effective to breathe through the nose while doing extreme activity than oral through the mouth. And if you breathe through the mouth, you lose out on the protective effects of the nose on the lower airway. As we know, that nose can account for about 50% of upper airway resistance. And if you look at it, increased ventilation during nasal breathing compared to mouth breathing is beneficial. Stimulatory effect of nasal airflow on central respiratory drive and upper airway stability. And the classic example of this is people with nasal packing, people who get packed posterior anteriorly in the hospital have issues with breathing. The diving reflex brings about central respiratory drive inhibition. Nasal ventilation is also associated with a higher amount of upper airway dilatory muscle activity. If you remember seeing Dr. Hopp's dilatory, the levator and tensor valley palatini activities on the Livanova implant, those were much more active if patients did not have sleep apnea. So we know that people can breathe through the nose better. Their effect downstream, it leads to dilation of the upper airway. What happens if you mouth breathe? It causes increased obstructive events, and if it's completely blocked nasally, the diving reflex will cause increased central events. There's lack of dilatory airway activity, and there'll be increased negative pressure as a part of increased resistance leading to collapse. So it's a cascade effect if you don't breathe through the nose and you breathe through the mouth. This is the classic Starling resistor effect, which shows that increased resistance, bigger gradient, bigger is the collapse. So here we see more negative pressure, more resistance, more collapse of the pharyngeal tissue due to the increased negative pressure. Again, if you open the airway up, release some of the pressure, you will lead to decreased interluminal pressure and decreased collapse, because again, greater the flow, greater the negative pressure, greater the pressure gradient, more the collapse. So you can look at various stages, what happens when people are breathing through the nose or breathing through the mouth. And you can see while you're awake, there's not much of a difference, but when you're asleep, you can see the difference in nasal resistance, in airway resistance, upper airway resistance. When you breathe through the nose, much lower, and if you breathe through the mouth, much higher. Again, as we said, classic example is nasal occlusion with packing, both anterior, posterior. Those are the days when we actually did pack people posteriorly. Everybody got to the ICU because of diving reflex and central sleep apnea. Though it's controversial, a lot of people said it was the oversedation with narcotics which caused the problem. Again, snoring, obstructive apneas, hypopneas. Just to go back to the controversial topic about phenotype of obstructive sleep apnea, I think not only that there are different phenotypes, it was also important to know what the apnea index is in the whole apnea-hypopnea index. People who have a higher apnea index do much worse than people who have majority of hypopneas and not as many apneas. Again, ODIs, oxygen desaturation index, lower the time below 90. If you look at the pulse oximetry graph, it's not linear, it's exponential. So drops in pressure, drop in oxygenation significantly reduces the oxygen carrying capacity of the blood. And I can see what happens when when you drop the pressures, oxygen saturation, and there's decrease of drive and increase of central apnea. Again, it's all physiologic from the time when we were mammals living in water. Anytime we held our breath, it also made the brain not breathe because they thought you were diving. Again, more arousals get you into the more superficial part of sleep, and then you start breathing again. Again, more arousals, poorer the sleep quality, and the sleep stages where you really want REM sleep to be at least 25% doesn't reach that important, because each time you hit REM, everything goes down, and everything goes down. Then you wake up, go to a more superficial sleep level, and you're not getting the rest you need. Again, what happens when the nose is partially obstructed? Most patients don't have a complete obstruction. And again, here comes both the parts of a septum and the dynamic part, which is the nasal valve, which comes into play for obstruction and increased resistance. So here we know that we have opportunity of both fixing the septum as well as the nasal valve to improve both the static and the dynamic factors in the nose. Again, there is no relationship between total nasal anatomy score and AHI. So you can look at the scattergram, there is no relationship. So people can have minor obstruction and major apnea, or vice versa. When treated, nasal obstruction improves nasal resistance, improves sleepiness, but does not affect the AHI number. So it does make a difference. It makes things better, but with respect to sleep quality, not so much as sleep apnea. Again, there was a sham surgery study done. Again, impossible to the US, this was a European study. Basically, which shows that apnea-hypopnea index remains unchanged. But interestingly, which did happen, that ESS actually improved in both groups. So even though the apnea-hypopnea index did not improve, the assessment of sleepiness, the degree of how it affects the person, did improve. And if you can look at here, scattergram, again, there's no correlation between responders and non-responders. Again, we know through DICE that people who've had nasal surgery versus pre and post, the collapse at the level of the palate and posteriorly did not change after nasal surgery for DICE. So it did not affect any obstruction at the palatal level or at the level of the tongue or the epiglottis. Again, you look at all the data here that isolated nasal surgery improves nasal resistance, Epworth sleepiness score, respiratory distress index, but the AHI is one parameter which does not change. And you can see at all these studies which were performed, and a meta-analysis was published of effect of nasal surgery on sleep apnea. So as Dr. Hopp mentioned, nasal obstruction is very common. About 25 to 40% of CPAP users say their nose is congested. Both objectively, you can see the cross-sectional area as well as the volume of nasal airways decreased and decreased nasal resistance. And once you've fixed it, you call it septoplasty with or without turbinate reduction, the nasal passageway, nasal resistance decreased significantly. Again, you can look at here that the significant decrease of CPAP pressures after nasal surgery, septoplasty with or without turbinate reduction. And that's the meta-analysis. And then the key here, which is what we really look for, what is the compliance? What is the compliance? What was the compliance prior and what was the compliance afterwards? In the first group, pre-nasal surgery, the compliance was about 38.7%, and post-nasal surgery almost became 90%. So there's obviously a benefit of sleep apnea treatment with respect to compliance with CPAP, which is still a gold standard for treatment. Again, this is just a case, nasal patency case, really badly deviated septum, with some people call from this morning, even pneumosinus dilatans, how big and pneumatized these sinuses are, an effect on nervous pathways. Again, fixed is the septum, framework, size of the piriform aperture, deviated septum, turbinate size pneumatization, as we all spoke about, and dynamic, which we're learning more and more about, nasal valves, inflammatory factors, including swell bodies, fluid shifts, and body positioning and effect of gravity on the nose. Nasal cycle, which again can be very dominant in about 15 to 20% of the population, which then would make their nose clogged up when they lie down. Again, what is our society's consensus statement? And the consensus statement, it says here, is septoplasty will improve the use of CPAP. And so that is what the indicators are. And so when we advise patients about need for nasal surgery, we really clarify that it's going to be for adjunctive measures, so you can use what helps you, oral appliance, CPAP, in a much more reliable and comfortable way. One of the key things for insurance purposes is when you do write for septoplasty or wanted to write for septoplasty, do clarify that it's not for sleep apnea It's for daytime congestion. Otherwise, they'll always be denied because there's no data to suggest that nasal surgery in adults affects sleep apnea. Again, expectations, expectations, expectations. Don't do everything on every patient, and address both static and dynamic processes. And I'll open up the forum for questions. Yes, sir.
Did you look at the contribution of nasal obstruction and the degree of active? Like, what I have found is that treating nasal obstruction in somebody who's got an early or minor degree of sleep apnea is much more effective than after they've developed a hypertrophy of the frontal muscles.
I mean, we experienced,
So,
yeah.
just going back to your original slide showing the degree of that, the airway and the pressures on the airway. Well, if you get to it before you develop the muscle hypertrophy, then nasal obstruction, relieving nasal obstruction is very significant. And also, have you looked at, with the use of the CPAP, there's a certain percentage of people that get worse with their nasal obstruction, and a certain percentage that get better with the use of the CPAP.
So all those are great observation. First is like Dr. Catalano will present his nasal surgery and sleep apnea affecting children. So I think in the adults, by the time you're doing all of this, you're probably behind the 8 ball already. That you already have those physiological changes in place. So if you have to address them, maybe time to address them is when they are younger to prevent the downstream physiological changes. I would guarantee that all of us experience when they have a bad cold, that we all have sleep apnea. I mean, again, we can't breathe through our nose, we're breathing through our mouth, we're unhappy. And I actually did a sleep study when I was sick. I had severe sleep apnea, and I have no other symptoms. When I did it with nasal congestion, I couldn't breathe at all. I had the flu, and I just said, let's see what happens. Went from no sleep apnea to severe sleep apnea on the same test. So I think we don't know sleep apnea. We don't have a good matrix or a good measure of what is good sleep apnea, what's bad sleep apnea. Should we now divide the indices into apnea index and hypopnea index and treat them differently? Because very often when we treat people, their AHI does not go down so much, but if you look at the nature of AHI, it changes from apneas to hypopneas. They predominantly become hypopnics. They don't have apnea anymore. They feel great. But our pulmonary colleague says, that's sham surgery, nothing changed. Look at the AHI index. So I think it's a time to look at a better index which will predict sleep apnea and also a better indicator of what sleep apnea outcomes are going to be surgically.
I just think that it makes a significant difference that when you implement, just like you said, should be looking at it children with sleep apnea is a developmental process. I don't think anybody's born with, maybe some people are, but it's mostly a developmental process. It's development, it's all, it's physics. It's airway mechanics. So, if you can prevent that hypertrophy of the muscle that develops from the chronic obstructive pattern and the negative pressures that develop, well, then nasal surgery is significant. But if you take all comers, with, sleep apnea, does it really help sleep apnea? The majority of people, the answer is going to be no.
At least in objective parameters, a lot of patients come and thank you for how much you improved their life. And I guarantee you, if you repeat a sleep study, there wouldn't be much difference in the apnea-hypopnea index, but their sleep quality, ESS, rebounds to be much, much better than what it was preoperatively. But at least today's understanding and what data we have, we cannot justify nasal surgery as a cure for moderate, at least for maybe some mild, but no more than very mild. Anything more than a mild, I think we need other things. This is a multi-level disease. So both hypertrophy and redundancy go hand in hand. a lot of redundant tissue. That if you look at the posterior constrictors, which we do for expansion palatoplasties, those are normally you wouldn't even be able to dissect them. In sleep apneics, you can actually get the posterior pillar muscle and the constrictor muscles are heavy enough that you can actually pull them up and do an expansion palatoplasty, and they anchor the pharyngeal mucosa. So there is combination both redundancy and some hypertrophy.
As an observation, I'd say about 50% of the people that do solely nasal procedures on for sleep disorder breathing at about 3 to 4 weeks post-operatively, they'll come in with their significant other, and the significant other will say, you know what, still sleeping with their mouth open, still snoring, breathing beautifully through their nose otherwise. I give them a chin strap, tell them to use a chin strap for 3 or 4 weeks, retrain them, they come back, it's gone.
Yep.
Snoring's gone.
Yeah. So we use a lot of chin straps as well.
That's really a big thing. It was years before I figured that out. I had a lot of applications for a long time before I figured that out, that they needed to be retrained.
Yeah, we keep that because routinely all our hyoid suspensions, all our Inspires or Livanovas, they all go home with a facial bra, just to support the tissue.
Why chin strap instead of mouth taping or
Oh,
one of those other devices?
Chin strap's just easy to get online, and the mouth taping, 2 things. Number one, I don't like when people put anything sticky on their mouth, reactions and that kind of thing. For some reason, all my sleep apnea patients have facial hair, and so it's not going to work anyway. Just always worry about something going on.
Yeah.
You have the way to get it on Amazon?
Yeah, $15 on Amazon. Yeah, it's $15 on Amazon. Yeah, no, in New York, after the New York Times article on Breath, the book, everyone comes with a mouth tape. I was like, oh, maybe the wives are beating you up. Yeah, not sexist enough. So you want to keep your mouth shut. Yeah, but I personally like either the facial bra or the chin strap.